There we go. How's that? This is mucormycosis is an important disease because it frequently presents as a medical emergency. It's an acute infection, and there's a lot of inflammation, thrombosis, and it characteristically will invade the arteries, and it follows along through the vascular system, which I'll demonstrate in a moment. This organism is all over. Have you ever had fruit and something you left in the refrigerator and it gets white mold on it? Okay, those are usually one of these mucor species. They're all over. Again, like if I wipe my finger on here and put it on one of those Sabrod dextrose agar plates, I'll grow out several species of these. People get them by inhalation, ingestion, and surface contamination. They're a big problem in burn patients. The burn lesion will get invaded with these. So in burn units, they go through quite a lot of procedures to keep infection. That's one of the biggest problems in burn patients is infection, because those burns heal by granulation, and they make a beautiful medium for bacteria and fungi. There are 3 genera. By far, Rhizopus is the most common causing disease, and mucor species and Epsidia. They occur worldwide, and their ecological niche is everywhere. Food, soil, any organic debris. And the biggest problem is the uncontrolled diabetic. And what typically you'll see is a patient, an uncontrolled diabetic, will come in and they'll probably be comatose. And the family will say, yeah, he has diabetes. Now you look closely, you can probably see the white mold growing in their nose. And what you got to do immediately, what's the first thing? Got to treat the diabetes, because that's why this thing is growing. And then, of course, getting cultures and identification to know what you're dealing with. But if you get any uncontrolled diabetic coming into the emergency room, you better think of mucormycosis. There'll be ketoacidosis in the patient, nasal stuffiness, and that's from actual physical blockage of fungal elements. You know what proptosis is? The eyeballs kind of bulge out because there's a mass growing behind them. And eschar, they'll have bleeding around the nose, and you'll see these scabs around the nose and in the mouth. It's amazing. They have this affinity for arterial invasion, and they grow in. So what happens is you inhale, the patient inhales it, gets it in the nose, and it grows right up, following the arteries and veins, and grows right up through the cribriform plate and into the brain. Direct extension, and they're rapidly fatal. This is a patient from MUSC, and he came in. I was about a 45-year-old black man. He had diabetes, and he came in comatose. And you could see the eschar here, and the eyes. You can even see that the eyes are bulging with the proptosis. Why does it? Because the question was, why does it affect diabetics? Because with the ketoacidosis, they just form a beautiful milieu for the fungus to grow. And then as well as it's right next to the brain. You inhale it, and the fungus has the arterial tendency to grow along arterial ways and goes right to the brain. And this doesn't show too well, but what it is, this is the skull is open. Do you do autopsies anymore? No? Well, Well, we always open the skull, and you cut it. This is the edge of the skull. And this is the brain reflected back, so you're looking into the two fossa. All this white stuff is pus. This is the same patient. And this is the pus that grew up to the cribriform plate. It's probably underneath here. And it grew up, and the fungus grew up in here. This is an example. I know the histology isn't great here, but because it's all distorted by organism growth. But this is the arterial wall. See this? You see all the fungi, it's dark purple, are the fungus growing in the arterial wall. These look round. Now, these are not yeast, but these are cross-sections of mycelial filaments. This is only in a mycelial form. And you can see the branching here, and you can see they're wide, and they're ribbon-like. They're often described as ribbon-like. This is a better example. Wide, non-septate, ribbon-like branching. In the culture plate, they'll grow up in 4 or 5 days. They're fairly rapid. Some of them are domatiaceous. You can see the pigment in the mycelium form here. Again, wide, septate, branching, ribbon-like. These are the fruiting bodies, and we identify them by the fruiting bodies: size, shape, color, and the placement of some of these filaments, which I won't go into with you, but that's how we identify them to species. Treatment, excuse me, control the diabetes, or if there's some other underlying disease that this patient has, but diabetes is the most common. Biopsy material to the lab, culture material to the lab, and then surgery and debridement. And lastly, amphotericin. It's still probably the drug of choice in this. Intravenous, rapidly acting, and you have the least recurrence of disease with amphotericin B. We have a serological test, an immunodiffusion test. That works pretty well. Okay. Remember, diabetics and mucormycosis. Now, this is becoming, aspergillosis is becoming probably one of the biggest problems in infectious disease, particularly in hospitalized patients. It causes all kinds of diseases, pulmonary, external ear, eyes, meninges, sinus, or bloodstream. If you get a person with an ear infection, you go in with your otoscope and start to look into the ear, you'll see the fungus right there just growing out, a bunch of seaweed, and it'll probably be white or black. There are 3 primary types. The allergic type is allergy. Kids with asthma and sensitivities to this disease. The next is fungus ball. The fungus ball, I'll show you some pictures. You don't see too much now. It grows within a cavity, an old TB cavity, where the TB has been cured, and there's this empty cavity. You inhale the spores of Aspergillus, and they start growing in there, and they grow like a colony, like on a plate, because there's air in that sac. And the third type, the big problem, is the invasive, where it grows through any tissues in the body, and it just penetrates through. The reason this is difficult to diagnose is because the symptoms are not specific. We'll talk about specific symptoms on the other diseases. The radiography is not specific, unless it's a fungus ball, which is very specific. but usually the fungus ball is not a big clinical problem. The blood cultures are seldom positive. Blood culturing for fungi in general are not real good. They're good for Canada. You can get most of those. But in general, blood cultures are not great. Serology is seldom positive early enough so that you know what you're dealing with. It takes a little while to become positive. And you need invasive procedures for early detection. Bronchoalveolar or lavages and that sort of thing. Going on in and take a look. There are probably 900 species of this organism, and these are the three most common: Aspergillus fumigatus, Aspergillus niger, and Aspergillus flavus. They occur worldwide. They're everywhere. They're in soil, decaying vegetation. They grow on foods. They grow in medications. They grow in air vents, and this was a big problem in the beginning of heart surgery. Many patients were infected with this. That was before we had all these HEPA filters on operating room air, and they would just come in through the air. Particularly if there was any construction anywhere nearby, the air would have the organisms in it, and they get deposited into the patient. And they'll even grow in disinfectants. I said 900, and I don't know why I put 100 there, but again, you got mycologists who are splitters and lumpers, so you'll get anywhere. There's a book for identifying these that's about this thick with more than 1,000 species in there on how to detect them. But fortunately, they're just the three that are most common. They are very slow growing. They have various colors, the gross colony morphology, which helps to identify them. And then the spores, and they vary in size, shape, texture, and color. When I say they vary, I mean they vary for each species.